Today we've got Beth and Nuala, who have kindly taken their time to present about end-of-life care. They're actually the co-leads for the palliative part of Mind the Bleep, or the palliative sector of Mind the Bleep. So I'll now hand over to them to introduce themselves further. Thank you.
Thanks so much, Shruti and Dan. My name's Beth. I'm a junior doctor working in the Northeast. I've just started a job as a palliative care teaching fellow, but just a few weeks ago I was an F2, and I'm very much still getting to grips with how we manage palliative patients as junior doctors and as part of the team. Nu?
I'm Nuala. I'm an IMT1 working in Northeast London.
Beth, I think you...
Technical difficulty.
Okay. If we have the next slide. Yeah. So today we're going to talk to you about DNAR conversations and just some tips for a bit of a structure for how to have those conversations. And then in the second half, we're going to talk about end-of-life care pathways, kind of in broad terms. Beth's going to talk about symptom management, and then I'm going to talk a bit about medication rationalization. I think there's a slide about OBS, hydration and nutrition, and then spiritual and religious care. So I'm sure you're all familiar, but just so that we know where we are. So DNACPR documents are a document that says that patient should not be for CPR in the event of a cardiac arrest. It's not a legally binding document, which means it's sort of clinical, it's guidance for the clinical teams, but there are situations where a team might decide to do CPR anyway. And it's also a medical decision. So we'll talk about kind of how to speak to patients and their families about it, but it's not ultimately their decision whether they're for CPR or not. That being said, if a patient has capacity and they want a DNACPR, they can. It's the difference between demanding a treatment and refusing a treatment. So because patients don't have the right in the NHS to demand a treatment, they can't have CPR just because they want it. It's a medical decision, but they can refuse to have CPR if they don't want to have it. So even if the medical team feel that CPR might be successful, if a patient is clear that they don't want it, you can put in a DNACPR. I hope that makes sense. So whilst it is a medical decision, best practice is that it should be discussed with the patient, and if that's not possible, a representative, so a next of kin, a family member or a friend. And there have been some legal cases in the past where they weren't discussed, and the kind of ruling now is that unless there's a strong belief that talking about the DNACPR will cause psychological or physical harm to the patient, it should be discussed. Okay, next slide. So I'm just going to talk to you about a sort of example structure for how you might have a DNAR conversation. So as an F1, you're most likely to be seeing these conversations happening in an acute setting, for instance, on the medical take. They do also happen in the community. They might happen at GP practices. Palliative care teams might have them at home. But as an F1, you'll probably be seeing them happen in hospital. And you're most likely to be watching your seniors have these conversations and documenting them rather than having them yourself. But there may be situations where you're asked to have a DNAR conversation, and if you feel comfortable, you can do. So I did have some DNAR conversations with patients as an F1 on the medical take. And there's no kind of one right way to have this conversation. And one thing I think is useful is when you are observing your seniors having the conversations, you can have a think about what you think went well in the conversations and what you think didn't go well in the conversations. And from that, kind of pick up your own technique for how you like to do it. this is just an example structure. This is how I tend to do it. And I think this works quite well because it's quite structured and aims to be quite clear. So the first thing I would do is introduce the conversation.
Oh, I think we've lost Nuala.
I will see if we can find her.
I think there must be some sort of internet connection issue because towards the end when she was speaking, it was just sort of we couldn't quite hear her. It was quite robotic sounding. Sorry, guys. Apologies for the technical issues today. I think we're having just one after another, which isn't usually the case. Please bear with us.
Yeah, sorry everyone. I will try and get Nu back. If we can't get her back quickly, then I will take over, but I'll just see if we can get her.
Hi, can you hear me? Yes, sorry, I think that was an internet failure on my part. Yes,
Yes, I can
sorry.
hear you and see
So,
you. Thank you.
okay, great. So yeah, I think I was just at the beginning basically. So you're just going to introduce the conversation, and check that the patient's happy to have that conversation with you, and you can ask if there's anybody that they'd like to have with them for the conversation. So the next thing I would do is I would explain what we mean by resuscitation and CPR. So it's easy to assume that patients will understand what these terms mean, but they actually may not at all. And I think it's in order for them to kind of know what the discussion is about, they need to understand. So I think it can feel like you don't want to be really explicit because it can feel scary, but I think it's best to be really clear. So I would say we're talking about the situation in which a patient's heart has stopped beating. And I say that in that situation, we have two main options. So one is to do nothing and allow that person to die. And the other option is to attempt to resuscitate them. And that involves a combination of compressions on the chest, using electric shocks to try to restart the heart, and normally doing things to help the patient's breathing, including putting a tube into their lungs to breathe for them. And most people, when you say that, they've seen enough on TV to know when you talk about the compressions on the chest, they know what that means. Then I would explain a bit about the risks and the benefits. And I think this is really important because what a lot of non-medical people don't understand is how rare it is that CPR is actually successful. And a lot of patients will think that it's successful most of the time. So the common risks, we could say, are that it's not successful, that it causes physical damage to the body, such as breaking ribs, and also that whilst we're able to restart the heart, there has been a sufficient period where the brain hasn't been getting oxygen, that there's damage to the brain. So the patient, we're able to kind of keep them alive, but there's damage to the brain, and that can be as significant as them not being able to talk and not really being able to have any independence. The benefit is that we keep the patient alive, and we can then carry on treating whatever medical condition it is that has brought them into hospital. I think it's also important to explain that it will not solve their other medical problems, and it will not, let's say they're being treated for a pneumonia and their heart stops and we do CPR and we are able to restart the heart, we're still going to deal with the pneumonia. It won't solve those issues. At that point, I would check that all of that's made sense. I would ask them if they've got any questions that they want to ask. And I would ask them if they have any thoughts or feelings about what I've said so far. At this point, I would then say that I would explain the medical position, and you can say that it's the team that's come to this decision. As an F1, you won't be deciding for yourself that the patient needs a DNAR. It's much more likely that a consultant will have told you that that's what needs to be done, and you'll be having the conversation sort of on the behalf of the consultant. So you can say that your consultant doesn't feel, for whatever reasons that are going to be specific to that patient, that CPR would be in their best interest. And I think it's important to make it specific to the patient based on their pre-existing medical conditions or whatever acute situation is going on for them. But ultimately, you're saying the medical team don't feel that it would be in their best interest because they don't feel that CPR would be successful. At that point, if the patient is in agreement, then you can complete your DNAR paperwork. If they're not in agreement, so you've explained that the medical team don't think that it's in their best interest, if they're saying, no, I really want to be for CPR, I really want you to do everything, at that point, I would ask your seniors to come and help you, because that complicates the decision making, and I think that's kind of above your level. I hope that all makes sense. We'll have the opportunity for some questions at the end. So if you have any questions about anything I've sent there, please let me know. Great. So now we're going to talk a bit about end-of-life care pathways. So what we mean by this is a kind of set of different things that are done for patients when they're recognised to be at the end of life. And we're thinking really in a hospital setting here, although all of this could apply in the community or in a hospice. Everywhere that you work is likely to have a different name for this. And there's often a sort of pro forma that you'll use that kind of triggers you to go through and think about all these different settings. So when you start working somewhere new, or you all will be new in whatever hospitals you've started working in, it's worth asking around, finding out what do we call it in this trust, and is there a document? But wherever you work, it's going to contain largely the same things. A lot of this will be being led by your seniors, and you won't be making these decisions yourself, but it's really helpful to understand what the different components of it are. And also sometimes I have found in my experience, the consultant will have quite a quick conversation. Then you're trying to fill in the paperwork and you'll realise that there are parts of it that haven't been addressed, and you might need to go back and talk to the patients or their relatives at that point. So I'll hand over to Beth, who's going to talk about the anticipatory medication.
Thanks very much, Nee. So we'll go through symptom management in kind of end-of-life care and palliative settings, thinking about our main symptoms that occur in palliative care. So these 5 are the 5 that you will generally be treating in hospital or community settings. A lot of them are very multifactorial and can influence each other. So, for example, agitation can often be influenced by pain and nausea, as well as fear and other emotional experiences. So it's really valuable to take the time to understand which symptoms our patients are experiencing so that we can then treat them, because they often kind of feed off of each other. Starting with pain, this is just a reminder of the fact that in palliative care in particular, we have this concept of total pain, where a person's physiological experience is influenced by many other factors. That's the case in all of our patients, but in palliative care in particular, it can be really worthwhile thinking about the kind of social, emotional, and spiritual factors that could be at play. When I'm approaching a palliative patient and thinking about how I might manage their pain, these are the main things I think about. So I think it's quite easy in palliative care to just think about treating and just jump in with pain management, but I think it's really worthwhile considering why they're in pain in the first place. For example, if a patient is in urinary retention, we can give them morphine, but actually a catheter might be more appropriate. So it is good to make sure that you do quite a thorough pain history. Knowing what they're taking for the pain already is also really useful. partly because it can help guide us in knowing what has or hasn't been helpful so far, and also because lots of patients will be on opioids and we want to avoid making them opiate toxic, so knowing what they've already had is important. That also brings me to what is their EGFR. If you have a palliative patient, it is really useful to consider their renal function before you prescribe, and we'll talk about that a little bit later. And then also considering, can this patient take orally? So lots of palliative patients may not have a safe swallow or may no longer be conscious enough to take orally, but it's useful to consider it before you begin your prescribing. So these are just the kind of main take homes to think about when we're prescribing for pain. Generally in palliative care, we skip straight to the top of the WHO pain ladder. It can still be useful to give paracetamol and adjuvants, but we'll often be giving morphine as our first line. Quite a lot of guidance is kind of recommend using oral where possible. So if a patient can swallow, using Oromorph can be a useful first line. We should generally think about prescribing regular or background medicines along with our PRNs. So hoping to provide a kind of background of pain medication that keeps the pain at bay, so then the PRNs are just used absolutely as and when needed. When we have palliative patients, we generally review their pain medicines every 24 hours, if not more often. And as an F1, it might be part of your job to be reviewing these pain medications at 24 hours and thinking about whether the dosage needs to change. In a patient who has been using lots of PRNs, you would normally think about increasing your background dose, so to create that kind of greater level of threshold before they need the PRNs. To do that, you add up your total daily dose, so taking all of the background and all of the PRNs, and that gives you your new 24-hour total daily dose. That being said, because we're often working with quite strong medicines, we wouldn't increase by more than 50% a day. So if a patient is using way over 50%, way over double what they were using, we need to think about carefully building up that increased background. Then we might need to recalculate the PRN dose or calculate it in the first place. And we generally look for a sixth to a tenth of that total daily dose in order to give an appropriate PRN. If you have any doubts, you will have fantastic pharmacists on all of your wards, and there'll be an out-of-hours pharmacist. And I have definitely called people in the past, making sure that my maths is right. It can also be really helpful just to get a colleague to check your maths. Now, the areas that we have to think about caution with would be elderly or frail patients and those with renal impairment. In terms of elderly frail patients, generally I try to go for a smaller dose as my starting dose, both for the regular and PRN. And you can also try and have larger numbers of hours between the dosings so that you don't knock them off too much or cause them to fall. In renal impairment, the rough guidance is that in moderate renal impairment, use oxycodone instead of morphine, and use alfentanil when you have an EGFR under 30. Alfentanil is a very short-acting medication, so we couldn't really use that as our kind of twice daily background. Normally you need to start a syringe driver so that you're getting a gradual 24-hour dosing throughout the day. Again, if you do have doubts in patients with EGFR of 11 or something like that, asking for some help either from a pharmacist or your palliative care team can be really helpful, and they really don't mind you asking. Moving on to nausea and vomiting, such a horrible symptom in any situation, but can be really awful in palliative care. In terms of general principles, similarly to pain, I would always suggest thinking about why this patient is nauseous and vomiting in the first place, and whether there's a reversible cause that we might be able to treat, because again, just antiemetics won't cure hypercalcemia, but if you give some fluid as well, that could make the patient feel much better. Thinking about environmental factors is important, and taking a thorough history from a patient can help you help make sure that they have less triggers to make them feel sick. So for example, if they are feeling sick largely when the smell of food is in the room, you might be able to chat to the HCAs and the domestics and see if we can get as little food smells as possible. In terms of the route that you'll go by, often people who are nauseous or vomiting are absorbing quite poorly, so subcut is generally where we'll start. I'm sure you'll have all gone through the horror of medicines for nausea and vomiting in med school, where you learn about all of the different receptors and the places that they work. That doesn't generally come up as a foundation doctor at all, but I suppose if you want to look into it more, that can help you think about why we use them for certain things. These, I'd say, are the top medications that we use for nausea and vomiting in palliative care. Some of them have quite important contraindications, so Parkinson's disease in metoclopramide and haloperidol, really worth thinking about. Levomepromazine is one that you may or may not use in your foundation years. It's very broadly acting, so it causes a lot of sedating effects. So generally, I've only seen that prescribed by kind of the specialist palliative care team, but they might ask you to prescribe it in a patient who hasn't been responding to other methods. When we choose antiemetics, we've got to keep comorbidities in mind and also previous medicines that have or haven't been helpful. Generally, if you have a patient who's approaching end of life, you'll have trust guidelines which you can follow. Often anticipatories come in a structured set where you just tick electronically the medicines you want, so you often don't need to choose. That being said, each antiemetic does have some kind of special features or aspects that make them quite useful. So haloperidol is found to be quite useful in chemical causes of nausea, so your hypercalcemias. Ondansetron is often useful in chemo or radiotherapy patients. Cyclizine is a bit of a jack of all trades and often will be your first line in end of life because it's useful for cause unknown as well as organ damage caused by cancers. And then the levomepromazine is often the last in the line, but can be really key in these nausea and vomiting that isn't responding to the other treatments. Moving on to respiratory secretions, so often kind of referred to as the death rattle, these secretions are the noise of your breath moving through your saliva if you aren't clearing your throat. It can make quite a kind of gurgly noise that some families find really disturbing and worrying, and it can make them worry that their relative is drowning or really uncomfortable. So communication is absolutely vital in management of secretions, more so than any of the other things that you can do. If I have patients who do have secretions, or even just patients approaching the end of life, I'll generally explain to relatives that as they approach end of life, as they get weaker and they're awake less and sleep more, they might become so relaxed that they don't notice the tickle in their throat that we do that normally makes us clear our throat. And they become so relaxed that leads to this noise that sounds rattly and uncomfortable to us, but to them is just a sign of how deeply asleep they are. It can be quite helpful to just let relatives know that, so that instead of thinking of the agitation their relative might be feeling, they know it's a sign of relaxation and not being aware of that. Alongside that, we can think about positional changes. So sometimes just moving the patient in the bed can be good. Suction can be considered if secretions are causing a lot of distress in the patient, but suctioning itself can also cause a lot of distress. So in most cases, I wouldn't say that's helpful. Then in terms of our medicines, hyoscine butylbromide is often the medicine that will be in your prescribing set for anticipatories, though glycopyrronium is also sometimes used. Agitation, similarly to everything else, considering reversible causes and trying to understand where the agitation might be coming from is really useful. Then ensuring as calm an environment as possible. So hopefully if your patient is approaching end of life, they might have a side room already, but if they're very agitated and they don't, you might be able to speak to one of the sisters on the ward and see if that's possible. ensuring familiar faces and familiar voices as much as possible, and then considering those kind of spiritual and emotional needs. So potentially involving the chaplain or having a conversation that the patient about what it is that the patient's worried about can be really useful, and it's really worth taking that time. Then in terms of pharmacological, midazolam is generally what we use. But I would definitely suggest thinking about the non-pharmacological as well. And then our final symptom that we're going to just touch on is shortness of breath. So lots of patients might become quite short of breath towards the end of life, even if they don't have a respiratory cause of what's going on. Alongside the similar reassurance that you would give for other symptoms, patients can find fresh air makes a big difference. So opening a window or getting a family member to bring in a handheld fan and fanning the patient can be useful. Mouth care can also help. If you have a very dry mouth and you're also short of breath, they can kind of exacerbate each other. So ensuring patients have keep their mouths moist. Oxygen can be used if the patient finds it helpful. Some patients will be very distressed by a nasal cannula or a mask, but others might find it has symptomatic benefit, so it can definitely be considered. Then in terms of medicines, morphine would be our first line, often at a slightly lower dose than you're using for pain. If the patient's already using morphine and that isn't proving helpful, or you're worried about them becoming toxic, you can think about midazolam instead. Then alongside the anticipatory medicines themselves, the final kind of part of your prescribing as an F1 might be prescribing syringe drivers. These allow us to deliver 24 hours of constant medication subcutaneously to a patient, and they're really important at the end of life or in tricky to manage symptoms. I wouldn't be expecting you as an F1 to be initiating a syringe driver all by yourself without kind of confirming it with a senior, but it might be that you are the person in the team who notices that a patient isn't on one and can suggest it, and the consultant might I think that's a good idea. The principles are exactly the same as all of the other methods. So reviewing at 24 hours every single day, adding up that total daily dose using the regulars and PRNs to create a new dose, and then making sure that your PRNs are adjusted if you do increase. So hope that wasn't too overwhelming. That's a kind of whistle-stop tour of the main symptoms that you might encounter in palliative care. Now I'll move on to Nu, who's going to speak about other aspects of care of dying patients.
So when around the time that you might be starting the anticipatory medications that Beth has talked about, you might also go through a process that we call medicines rationalization. And this is basically stopping any unnecessary medications. The main thing that you're thinking about here is the likely potential benefit from that medication versus the potential harm or distress of trying to continue to give it to the patient. And so essentially you keep going with anything that you think is going to provide symptomatic benefit. And this is a bit of it's a clinical judgment. And if you've been asked to rationalize somebody's medications, which you might be asked to do, and you have questions about specific ones, I would definitely just ask somebody whether they think it's a good idea to keep going or not. Ones that you're likely to stop will be things that are kind of chronic medications that are providing long-term prognostic benefit. So that's things like statins, blood pressure medications, any supplements if people are on calcium and vitamin D, these kind of things that are useful to a patient in the long term, but in the short term aren't going to affect their symptoms. You're likely to stop all of those. And then in other cases, it's going to depend a bit on whether the medication is likely to be providing symptomatic benefit. For instance, with antibiotics, you might make the decision, and when I say you, I sort of mean the medical team in general. I don't really mean you as an individual, but the team might decide to stop antibiotics because they might feel that there's no benefit to be had from those antibiotics anymore. Or they might feel, sometimes if a patient is thought to be septic, sometimes antibiotics will be carried on because the feeling is that it might be controlling the infection enough that it's making the patient a bit more comfortable. But it really is a kind of clinical judgment. And I would say, if you have questions, as I say, I would ask. And some of these decisions are going to be made through discussions with patients and their family members as well, because stopping medications can be a very emotive thing for patients and their families. And sometimes medications are continued really to avoid the psychological distress of stopping them. So it might be that the medical team feel realistically that the antibiotics are not helping anymore, but that the patient or their family really want them to be carried on, and that ultimately it's not causing that much harm to keep them going. So I think it's important to have, and again, this is really, your seniors will be leading on these discussions, but normally there's a flexibility in the approach about what we keep going and what we stop, based on what's going to give symptomatic benefit, but what also might cause psychological distress to stop. And there may also be a bit of a two-stage process of rationalizing medications. So you might stop initially some of those really long-term prognostic benefit medications like statins, but keep going with things like antibiotics. And then there might be a point later on where the patient is much less alert, not able to take any oral medications, and you might kind of stop another round of medications. The other thing is, sometimes if patients are receiving IV medications, for instance, IV antibiotics, you might say, and again, this would be a conversation that your seniors would really be having with the patient and their families, but there might be an agreement that you'll keep going whilst you have IV access, but that if the cannula tissues or something similar happens, let's say the cannula is accidentally pulled out, that you wouldn't recannulate to keep going with that medication. And that can be a helpful kind of conversation to have, even at the point where the cannula is still working, to just kind of lay the groundwork for what you will do if it stops working. Okay. Thank you. So then, to say a little bit about observations. So the normal thing that is done at the end of life is that you stop your standard observations, the ones that are done to provide you with a news score, and instead you start what are called comfort observations. And this is where a nurse or a healthcare assistant will go in and regularly assess the patient for any signs of discomfort. So they'll do things like look for pain, look for shortness of breath, look at the mouth, all the things that Beth has talked about, and assess the need for any of the anticipatory medications or any of the non-pharmacological methods to manage those symptoms as well. And I think this can be a really helpful thing to let patients and their families know that you're going to be doing, because when you're having these conversations about kind of approaching the end of life and making these changes in a patient's care, it can feel like a lot of stuff is being taken away. So we're withdrawing lots of medication, and I think it's really important to emphasize the things that we're still doing. And this, I think it can be really comforting for patients and their families to know that we're still actively we're still actively caring for the patient. We're regularly assessing them so that they know that they're not sort of being forgotten. Thank you. Next slide. So a little bit about hydration and nutrition here. So this is hydration and nutrition at the end of life is a really big topic and could be definitely a whole hour on its own. But I'm just going to briefly go through the options. So what we have here is kind of these are the options in general terms for how we can deliver hydration and nutrition. So the first one is oral intake as is tolerated by the patient, and that's sometimes called taste for pleasure. The second one is subcutaneous fluid. The third one is IV fluid. And then the final one is NG feeding or PEG feeding. And I actually should have put TPN in there as well. So I'm going to go through these again and just say a little bit more about them. So the first option here, oral intake as tolerated, is where we encourage the patient to eat and drink as much as they can, as much as their alertness allows, and we accept that they're not going to really meet their nutritional needs, but that's a natural thing that happens at the end of life. And we're focusing on comfort and pleasure. So we're encouraging patients to eat whatever foods they fancy and things that we know that they like, and to drink as much as feels comfortable. And we may at that point be accepting that there's an aspiration risk, but that the benefit to having a bit of oral intake is greater than the risk from the aspiration. And that's probably the most common way that we deliver hydration and nutrition at the end of life. And as patients become more drowsy and less alert, their oral intake will decline. And it's really useful to kind of preempt conversations with patients and their family that this is completely normal, that at the end of life our need for food and fluid goes down, and that the main thing is to keep them comfortable and to just focus on mouth care, because we know that that's the kind of the main discomfort that patients have, is feeling that their mouth is dry. So the two options, the next two, subcutaneous fluid and IV fluid, are ways that we can provide artificial hydration. Subcutaneous fluid, so just like you can have a syringe driver, which is a little needle that sits under the skin and delivers the medication, you can also have a similar setup where there's a small needle that sits under the skin and delivers fluid very, very slowly. You can't deliver it fast at all, but a really slow delivery of fluid into the subcutaneous tissue. And then IV fluid, as you'll all know, is just into a cannula. The decision to offer these is, again, a clinical decision that I wouldn't expect as an F1 you'd be making yourself. They would be decisions that your seniors would be making. And again, it's a sort of risk versus benefit decision based on how uncomfortable the patient is, how dehydrated they feel, and the risks of providing the fluid, because the risk is that the fluid goes into the lungs or into the peripheral tissues and isn't actually hydrating them. And one thing we know is that subcutaneous fluids and IV fluids don't improve the symptom of thirst. So whilst they might be getting some fluid into the bloodstream through this, the main thing that we're focusing on at the end of life, which is their symptoms, are not improved by this. But again, it wouldn't be your decision to make. It's just something to be aware that they are ways that fluid is delivered at the end of life. And then the final option here, which is NG feeding, PEG feeding, and I should have put TPN on there. These are things that would not be introduced at the end of life, but the relevance to end of life care is that sometimes they would be withdrawn. So if patients have come in with a pre-existing PEG or TPN, or they've been started on NG feeding during their admission and then they've deteriorated, at some point the decision will be made to withdraw those. And that would be a decision that your seniors, possibly with the help of the palliative care team, are having. Thank you. And then the final thing to say is just thinking about the patient kind of more widely in there as a whole being, is thinking about spiritual and religious care. So Beth talked earlier about involving the chaplain, and it's always worth asking patients if they are religious and if they would like to speak to the chaplain. The provision will be different at different hospitals, but they're normally multi-faith chaplaincies, which means that whatever the faith background is of the chaplain, they will support patients of all religious backgrounds. And they can also be helpful if they don't have a representative of that patient, of the patient's faith within the chaplaincy team. They can also sometimes try to find somebody for you. But also for patients who aren't religious, there's also kind of other ways to look after the patient as a whole being. And I think as an F1, this isn't necessarily your job, but one thing that you can do, which I think is a really nice thing to do, is to speak to the family or the next of kin, whoever's visiting, and ask them if there's anything that they want to bring in that they think would be nice for the patient. So I've got some examples here of that they could play music, they could bring in photographs of loved ones, they could bring some, depending on where you work, especially if you work in a sort of hospice or a palliative unit, you might be able to bring in pets. Sometimes it's possible for patients to be taken outside, and that can be really nice. And all of these things are just ways that we look after the patient as a whole being rather than just as a kind of set of medical conditions. Okay, I think that's everything that we had to talk about. So I can see a few questions in the chat. So if you have any other questions, please feel free to post them. So somebody has asked here, can an existing DNAR be refused later on? So I think what you mean by that is if the patient is in agreement at the time that the DNAR is put in place and they then change their mind, can they kind of then refuse it? And basically, because it remains a medical decision, they can't kind of say, oh, I actually do want to be for CPR, and then they would automatically have the DNAR removed. It might be that they do kind of change their mind and start to express that they want to be for CPR. And at that point, your seniors would need to have a conversation with them. It's a medical decision, so ultimately the medical team's decision would still stand, but it would involve some further discussions with the patient, trying to understand what's changed from their perspective, why they've changed their mind, and kind of going from there. And somebody else has asked, do we need to memorize formulae for converting dosages from MST to syringe driver morphine drugs? Do you want to answer that, Beth?
Absolutely.
Right.
I mean, so I would say no in terms of memorizing. I personally don't memorize any of the conversions. So I think what you're referring to is the fact that, for example, 5 milligrams of oral morphine is going to be a different strength from 5 milligrams of subcut morphine. And so it might be that if we're going from kind of oral to subcut or going from one route to another, we might need to convert it. So change the dose by timesing it by a certain number. I use an opioid conversion table. So you can find them. I use a palliative care guideline in the Northeast that has it in it, but you can also Google opioid conversion chart, and it shows you a very useful table that will generally tell you, if you're going from this to this times by 0.5 or something like that. But I've never memorized it, and in a way I think I probably never will, because it means that you're always making sure that you're getting the maths right when you do convert. But I don't know, Nu, is that?
I agree. Yeah, I think I don't know about some of you might have learned them for your finals, and certainly for postgraduate exams sometimes you have to learn them, but in practice I always look them up, because I think even if I think I know what it is, I just want to be sure, so I would always look it up. Yeah. And then somebody's asked, what are the common modes of death in patients with functioning defibrillators, e.g. active ICDs in situ? So I have no idea. I think what you're asking is if they have a defib in place, if they have a cardiac arrest, then they'll be shocked. So what do they die of if the defib is working? I wouldn't be able to tell you. Do you have any ideas, Beth?
No, not if the defib is working. I think
no.
I think you might need to ask a cardiologist or someone who knows in terms of the defib itself and what they might die of.
Yeah, but I think that raises a good point, which is if you're ever looking after somebody who is end of life and you know that they have a pacemaker, it's important that the pacemaker is deactivated before they die. So normally where I've worked before, the cardiac physiologist can come and kind of properly disable it. But if it's if the patient is acutely unwell and you're worried that they might die before that process can happen, you can normally get magnets, and I would speak to your palliative care team about where you get those from. But it's like a big magnet like this, which is basically taped over the pacemaker, physically taped to the chest, and that deactivates it whilst you're waiting for the kind of proper deactivation to happen.